system relies on the antibodies as one of its main defense mechanisms against infection. These antibodies exist in several classes, each one with a specific role in protecting the body. Although the name of these conditions implies that the affected individuals always have high level of immunoglobulin M or IgM, some individuals actually have normal level of this antibody. However, people with X-linked hyper IgM syndrome have low levels of the three other classes of antibodies, namely IgG, IgA, and IgE. As a result, the lack of certain antibody classes makes it difficult for people with this disease to fight off against infections. Therefore, individuals with X-linked hyper IgM syndrome begin to develop frequent infections in infancy and early childhood. The examples of the common infections are pneumonia, sinus infections or sinusitis, and ear infection, or also known as otitis. Furthermore, some individuals might have low levels of white blood cells called neutrophils and develop autoimmune disorders and increase the risk of lymphoma. As indicated by its name, X-linked hyper IgM syndrome follows an X-linked pattern of inheritance. The gene associated with this condition is located on the X chromosome, which is one of the two sex chromosomes. In males who have only one X chromosome, a single altered copy of the gene in each cell is sufficient to cause the condition. Meanwhile, females have two X chromosomes, so a variant must be present in both copies of the gene to cause the disorder to occur. Since it is unlikely for females to have two altered copies of the gene, males are affected by the X-linked recessive disorders much more frequently than females. In addition, a characteristic of X-linked inheritance is that a father cannot pass X-linked traits to their sons.
In this section, I'll explain the mechanism of X-linked hyper IgM syndrome and how a genetic defect leads to immune dysfunction. To make the process clearer, I've summarized it using mimic flow starting from the gene mutation and ending it with the immune outcome. X-linked hyper IgM syndrome is caused by mutations in the CD40L gene, which is located on the X chromosome. This gene normally provides instructions to produce CD40 ligand or CD40L, a protein expressed on activated CD4 helper T cells. What's important here is that base deletions or frame shift mutations disrupt the DNA reading frame, resulting in an absent or non-functional CD40L protein. Moving along the mimic flow, the next step shows how this defective protein affects immune cell communication. Under normal conditions, activated helper T cells express CD40L, which binds to the CD40 receptor on B cells. This interaction is a critical signaling step that allows B cells to become fully activated. However, in X-linked hyper IgM syndrome, the abnormal CD40L cannot bind effectively to CD40. As a result, the B cell interaction fails and the immune response becomes poorly coordinated. The final part of the mime illustrates the effect of this signaling failure of antibody production. Without CD40-CD40L signaling, B cells cannot undergo class switch recombination. This means they remain in their default state and continue producing only IgM antibodies, while IgG, IgA, and IgE are not produced. This text explains why patients may have normal or elevated IgM levels but still suffer from severe immune deficiency. In summary, the flow shows that gene mutations leads to defective CD40L, failed TB interaction, impaired class switching, and restricted antibody production, which fully explain the disease mechanism.
After understanding the disease, we can now look at the clinical symptoms. These symptoms help us recognize the disease early and understand how it affects patients in daily life. For patients with X-linked hyper IgM syndrome, symptoms usually appear very early in life, often during infancy or early childhood. This happens because once maternal antibodies start to decrease, the child's immune system cannot compensate properly. As a result, infections begin occurring much earlier than in healthy children, which is an important warning sign for medical practitioners such as doctors. One of the most noticeable features of this condition is recurring infections, particularly in pneumonia, sinus infections, and ear infections. These infections tend to occur repeatedly and may be more severe or harder to treat than usual. This is mainly due to the lack of IgG antibodies, which are essential for protecting the respiratory tract against bacterial pathogens. Next, many patients also experience chronic diarrhea, which can significantly affect their nutrient absorption. Over time, this leads to a condition known as failure to thrive, where children show poor weight gain and delayed growth. This highlights how immune deficiencies can affect not only infection control, but also their overall physical development starting from children. Another important symptom of this condition is neutropenia, or also known as low levels of white blood cells. Since we learned that neutrophils are a key part of our body's first line of defense against infections, their reduction in our body further increases susceptibility to bacterial infections. This makes infection management more challenging in these patients. In more severe cases, patients may develop organ-related complications. This can include liver disease, autoimmune disorders, and infections involving central nervous system. Such complications show that X-linked hyper-IgM syndrome affects immune regulation throughout the body, not just antibody production. Finally, patients with this condition have an increased risk of developing certain cancers, particularly gastrointestinal tumors and lymphomas. This increased risk is due to impaired immune surveillance, where abnormal or malignant cells are not effectively detected or eliminated. Because of this, long-term monitoring is especially important for people who are infected with this condition.
First of all, hyper-IgM syndrome is a rare but serious immunodeficiency, and diagnosing it requires a careful integration of clinical suspicion, laboratory findings, and also genetic confirmation. So let's walk through the process in details. The first step is clinical suspicion. This condition typically presents in early childhood, most often in boys, because of the defective genes lies on the X chromosome. So clinicians should be alert when a child experiences recurrent bacterial and opportunistic infection at a very young age. Common manifestations include repeated episodes of pneumonia, chronic diarrhea, and failure to thrive. These symptoms reflect the immune system inability to mount effective response. A family history of affected males is another important clue since the inheritance pattern is X-linked. Once suspicion is raised, the immunoglobulin profile provides critical evidence. Patients usually have elevated or normal levels of IgM, but strikingly low or absent level of IgG, IgN, and also IgE. This imbalance indicates defective immunoglobulin class switching. In a healthy immune system, these cells switch from producing IgM to another antibody classes after interacting with T cell. In X-linked hyper-IgM syndrome, this process fails, leaving patient dependent on IgM, which is less versatile in fighting infection. To probe the mechanism further, flow cytometry for the CD40 ligand is performed. Normally, when T cells are activated, they express CD40L, which interact with CD40 on B cell to trigger class switching. In X-linked hyper-IgM syndrome, activated T cells fail to express functional CD40L. This absence is a strong functional marker of the disease and help distinguish it from another immunodeficiencies. And now I will be talking about flow cytometry for CD40L. First of all, sample preparation will be conducted where peripheral blood mononuclear cells, PBMC, are isolated from the patient. Then, cells are stimulated in vitro to induce CD40L expression on CD4 T cell to activate the T cell. And then the fluorescent staining labeled monoclonal antibody against CD40L are applied. At the end, the flow cytometry will give us results where in healthy individuals, activated CD4 plus T cells show strong CD40L surface expression. Meanwhile, in X-linked hyper-IgM patient, CD40L is absent or markedly reduced even after the stimulation. Finally, clinicians must consider the differential diagnosis. Other forms of hyper-IgM syndrome do exist, caused by autosomal recessive mutation in genes such as IGDA, UNG, CD40, or NEMO. These present with similar immunoglobulin pattern but differ in inheritance and underlying mechanism. Secondary immunodeficiency, particularly HIV infection, must also be excluded, as they can mimic the clinical picture.
So now we are going to look at the management and interventions for SHIGM. So the primary approach is to prevent infections, replace the absent antibodies, and to correct the immune defect. So currently, they are focusing in combining the lifelong supportive therapy and curative interventions. Currently, there are 3 treatments for the patient, which is immunoglobulin replacement therapy, antibiotic prophylaxis, and hematopoietic stem cell transplantation. So let's look at the first therapy, which is immunoglobulin replacement therapy. So the purpose of this treatment is to provide IgG antibodies that patients' immune system cannot produce. The method is via intravenous IVIG or subcutaneous CSIG infusions for every 3 to 4 weeks. The effect of this therapy is the risk and severity of bacterial infections will decrease. However, this therapy does not treat the defective genes and it's required for lifelong therapy. So now we are going to proceed to the second therapy, which is antibiotic prophylaxis. So for antibiotic prophylaxis, antibiotics are given in advance to prevent infections before they occur. To prevent opportunistic infections, they are, for example, using trimethoprim, sulfamethoxazole, TMP, SMS to prevent pneumocystic girovecii pneumonia. They are also used broad spectrum of antibiotics to go against recurrent bacterial, for example, sinusitis. Antifungals or antivirals also used if the patients develop opportunistic infections. So now we are going to look at the third therapy, which is the last one, is hematopoietic stem cell transplantations. This therapy is the only curative options, which is it replaces the defective immune system with healthy donor stem cells. This therapy is best performed early before organ damage, especially for to prevent liver disease. The challenges for this therapy is it's require matched donor and the patient can develop graft versus host disease and transplantation complications after the transplantation process. So the successful HSCT can restore the patient's normal immunoglobulin production and immune functions in the patient's body system. The future treatments for SHIGMs, there are currently 2 therapies which are still under experimental and research phase. The first one is gene therapy. The purpose is to correct the ST14 ligand mutation directly in patient cells. The approach is via viral vector delivery or CRISPR based editing. So the status is this therapy is still under research phase and it is promising for long-term cure. So the second one is targeted biologics, which is they are doing research into cytokine modulation and immune signaling pathways. So this therapy is might help in reducing the inflammation and improve immune balance in patients' body system.